Hello, the world. I hope you all are well. This is Mostafa Sarabzadeh with another new episode of WomenSportPress under the section of Sport Medicine. Should everyone ask whether it is possible to heal a ruptured anterior cruciate ligament ACL without surgery, or whatever we would call us, as an invasive method a decade ago, no expert or leading researcher working in the area would dare to say, yes, it is likely. But now, you all know, all the thanks to the recent advancements in research and bracing technology in rehabilitation, by which our researchers and physiotherapists may claim the full recovery of ACL tear without the least surgical procedures. However, there are still a large number of contradictory comments on these claims and findings, predominantly made by surgeons, making any scientific debate or research on ACL rehabilitation a necessity more than before. Up to date, we all know the research has shown that ACL rupture has been reported to associate with the development of osteoarthritis, irrespective of severity, followed by long-term physical and psychological outcomes. These debilitating symptoms and comorbidities may make individuals think that a torn ACL has a limited ability to heal on its own, so that the surgery would be the only option on the table. But new studies have suggested otherwise. Reporting physical therapy and bracing protocol could be as much effective as ACL reconstruction, or even in some cases with far much better results on knee stability and function. So the good news, by the way, is no matter how competitive or pivoting your sport is, these new findings guarantee you a safe and relatively a quick return to your career. But how and through what mechanisms and to what extent are the type of questions you all might have raised now, and the answers will come within our today's talk through our wonderful guest, who is one of the number ones and leading scientists, pioneered non-surgical ACL recovery in the world. She also received a national award named Dame Kate Campbell because of the substantial impact she made on the healthcare practices through groundbreaking research projects. Yes, you might have all guessed who I'm talking about, ladies and gentlemen, Professor Stephanie Filbay from Center for Health, Exercise and Sport Medicine, Department of Physiotherapy, based in University of Melbourne, is here with us. Thank you so much for considering my work to join our program in WomenSportPress. The real thing is, I would say, please accept my apologies for my kind of my scratchy voice. I might have gotten some kind of cold like disorder. So this will be lying with us over the whole meeting today. Yeah.
Oh, it sounds fine so far. I thought you just had a deeper voice, so you can't tell.
Okay. So, dear Stephanie, if you have any updates with your days, which I'm sure you've been so much busy as an academic.
Happy to be here. Thanks for the invitation. Regarding updates, so research updates?
First, maybe let's better to go with your routine these days, these weeks, and how the life is going with you there, and then the research updates, actually.
Okay, how's life going? Right, well, still summer here in Melbourne, which is always nice. Nice weather, nice and hot. Bit unpredictable though, so 43 degrees one day and then 17 the next day. That's what we get here in Melbourne. But yeah, it's always a nice time in Melbourne around summer. So I've been taking some trips on the weekends to some wineries and other things, which is always nice.
Maybe city trips.
Yeah, weekend trips, just exploring Victoria, more locally, but there's lots of nice places to explore, hikes and that type of thing around here. Work is busy. So I'm full-time research. I'm a physiotherapist, but I'm now currently full-time in research, which means, running and doing a lot of different studies at once. So it's always a bit of a juggling act, I suppose. Juggling lots of different research projects and moving them along. And I'm sure we'll get into some of those projects a bit later in the podcast.
I got through some of your podcasts over the internet. Okay, how about your wonderful research work and how it goes now? As far as I know, there will be some research works underway to get published by you in the case of non-operational ACL rehabilitation. So could you please share with us what it goes with you?
Sure. So two of the main areas that we're moving forward in relation to non-surgical treatment. So one is related to informing decision making when it comes to ACL surgery or rehab alone. So who is a good candidate for surgery and who is a good candidate for non-surgical treatment, and informing the patient so they can make a decision that aligns with their needs and preferences. So we have done quite a bit of evaluation in Australia and found that the information that people are given isn't based on evidence. And it often is more biased towards surgery, saying that surgery is needed if you want to return to sport, that your knee's more at risk of further injury if you don't have surgery, and other beliefs like this, which actually isn't supported by the evidence that we have available. So based on those studies, we've developed an online patient decision aid that clinicians can use and patients can use, and they can work through that to try to make an informed decision. So we weigh up the pros and cons and educate them about likely outcomes and what each treatment involves. So that's freely available online at www.aclinjurytreatment.com. And then we're taking that decision aid, we've piloted it, and we're looking at now evaluating that in clinical practice to see if it changes the rate of people who are having surgery using a randomized control trial. So there's a lot of work around that and decision making. And then the other topic, which is, I guess, garnering quite a bit of attention, is around ACL healing. So we're looking at, we're doing a lot of work around whether the ACL can heal and what treatments can be done to facilitate healing. So quite a lot of studies in that space. We've started a large multi-site randomized control trial in Australia where people are randomized to either ACL reconstructive surgery or the cross-bracing protocol in an attempt to heal the ACL non-surgically. So we're doing that, but we're also doing quite a bit of work around predicting who's most likely to heal, the relationship between healing and knee function, and quite a lot of other studies in that area.
That's wonderful. Dear Stephanie, I personally guess the more we work on this topic, the more we need to go with, and as I found, there has to be lots of gaps, specifically, misconceptions made by not only patients and the public, but also by clinicians and the healthcare professionals, which is something kind of alarming because it directly affects the people's overall health. Why we can go with modern informed decisions based on evidence. So thank you, dear Stephanie, for all of this wonderful work you're doing. How would it be like to be to research on knee health as someone who has got itself her ACL ruptured several times, and carrying on some kinds of lived experiences of being treated and recovered several times through different modalities, as far as I know. So, could you please give us some insights on that?
Sure. Yeah, I mean, I think it certainly helps to have lived experience in the area that you're researching, definitely. Um, I've done a bit of qualitative research as well as quantitative, which is interviewing people with, ACL injured experiences. And I think it really helps to know the psychological side of it as well and to have experienced that. To have experienced the challenges with making, treatment decisions and being in the healthcare pathway and having been told certain things from other clinicians. I mean, I'm also a scientist, so I'm aware that my perspective is just one, and so I like to think it doesn't bias my perspective, but it does help, I think, to understand and to empathize and relate to people who have had ACL rupture. My PhD was on long-term quality of life after ACL injury and trying to improve that. And so I think having that lived experience really did help. But in saying that, I had ACL reconstruction. I was 18 at the time, and I was told that if I ever wanted to return to sport, that I had to have surgery. And that was some years ago now, but our recent survey found that most people are told that today, so it hasn't really changed over time. And to me, I remember at the time, well, there isn't a choice to be made here. Of course, I want to return to soccer that I was playing at the time. This isn't a choice, so I have to have surgery. And I was quite enthusiastic about that, going in to get my ACL fixed and returning to sport. So, I know that that isn't everyone's experience, but it is a common experience. So having lived that, and then I returned to soccer and re-ruptured the graft and had revision surgery, and then went on to re-rupture that graft. And then I had the experience of still trying to be active with, a lot of knee pain, swelling, and poor knee function, and then the onset of osteoarthritis. So that trajectory over time is unfortunately quite a common experience for people who rupture their ACL, especially in that group I was in, young female soccer players who return to soccer. They have a really high rate of graft rupture and a high rate of poor outcomes as well.
So that would be great to have those experiences as someone who is working on this area, but we couldn't be that much unfair to wish everyone to get those experiences of injury. Uh, Back to the where you ruptured your ACL, Stephanie, how did you do psychologically? Uh, I'm saying psychologically because I know for the girl who was at 18, maybe not having enough knowledge to uh, go with uh, physically and scientifically as you are now. So, uh, could you please describe how did you react to all those injuries from the psychological perspective?
Mm, right. Yeah. I mean, of course, it's challenging. Um, we call it, from the research perspective, a loss of athletic identity. But I think it also feels somewhat like a loss of sporting potential, especially if you're quite a talented athlete and you're young.
Mm-hmm.
You often have ambitions to play professional sport and are on that pathway to do so. And so when something like this happens uh, after surgery, I mean, I think it often doesn't hit a lot of people before surgery until they wake up from that surgery and realize just how painful and the poor function and how long and challenging that rehab's going to be and is. Um, so I think they then have to suffer kind of twofolds, often from being out of a sporting team and having to step away from sport that they've typically played their entire lives, but also this question over, will I be able to play again? Will I be able to perform at that same level? For many people, which is a high level. Will I now be able to, whatever their dreams might have been, Olympics or becoming a professional athlete? And then there's often a lot of setbacks. So like in my case, I had a cyclops lesion and had to go back in for surgery. And after the second surgery, the tibial screw extruded itself and unscrewed itself from the bone, and I had to go back in to have surgery to have the screw removed. So lots of somewhat setbacks, I suppose, over time as well. And then having to live with, in my case, my knee never really recovered, which often people say the knee never felt normal again. Sometimes they say it was 90%, but never fully normal. And I think having that expectation and living around that, but reconsidering or adapting to the role that sport plays in your life, or in some cases, ignoring the knee function and pushing on anyway to try to perform in sport, is challenging psychologically. As part of my PhD, I found that people who could step away from competitive sport and find another form of physical activity, like perhaps the gym or jogging or something that's lower demands on the knee, tended to be able to maintain a really high quality of life. It's those who are really attached or driven to certain sports, and then if they can't perform at that level or they can't return, they really do risk in terms of mental health and psychological adjustment.
So, have you did you play football, soccer,
Yes.
semi-professional level?
So at that, so I was sort of newly 18 and I'd started in a state Premier League, like the highest level in the state, but wasn't professional. But, there was quite a lot of international players in that team, and I was the youngest in the team and a striker. And so it was kind of on that pathway, I suppose. Yeah. So
So you never back to the professional sport after your surgeries.
no, and I think those setbacks, because I had those other, it meant 2.5 years before returning, and then another injury, and then another 2 years. Like it took such a chunk of time. largely due to the graft re-ruptures. That, yeah, and I guess the knee issues as well. It was always sort of a bit of swollen and painful, and it never really returned or recovered fully. And then I was at the stage where I just felt it's harder. You're a bit old. You're too old, right? So I think there's more opportunities to progress when you're young. People are looking for sort of young talent, certainly not later 20s type of age. That's too late to, yeah. So it's something that a lot of young females, I think, have to contend with. Definitely.
You're right.
Yeah. And we say, the ones that make it to professional sport, they're the survivors. There's a lot of girls that came before with a lot of talent that might have done their ACL at 16, 17, 18, and they never made it, but they could have had they never have injured their ACL. So, because it does really impact that talent development and that trajectory.
Yeah, maybe that's because our system is not well prepared to react with those. I mean, the medical system and the sports system, are not well prepared, qualified to react with those cases. I mean, the young girls or young athletes who kind of sustain ACL injuries several times and want to get back to a sport. I know the research is going on, but if we back to the last decade and specifically in some developing countries, and if we look at how these systems react to those incidences, it would be highly disappointing, and and nothing
Yeah,
else
and they
could
don't
be
they don't
worse than that.
necessarily get the same. Oh, sorry, they don't necessarily get the same support. If you're already a professional athlete, you get a lot of support to get back to sport. Everyone's pushing you to. That's the main goal. You've got rehab, you've got support, but young females especially sometimes can get less support than their male counterparts who are talented athletes at a younger level. So I think, especially if they're on the trajectory but not quite there yet, they can often therefore be overlooked for another player who doesn't have an ACL injury, so it's, yeah, and that all ties into the psychological coping and the psychological impacts of the injury for the young female athlete for sure.
So thanks, dear Stephanie, for your response. I hope you got back instead to your routine sport and day-to-day jogging, running, by the way.
Yeah, I definitely got back to sport. That's why I kept injuring my ACL. But then I eventually gave up soccer and took up Australian rules football, which is, I'm not sure if you're familiar with that, but no. Anyway, but these days I just do a bit of CrossFit at the gym.
Yeah,
Yeah, so
I'm not a
something a
big
bit
fan
lower
of
risk.
the gym and gym works. I would rather to go with endurance activities, long-lasting endurance, and as I was kind of triathlete after
Great.
retiring from soccer, which I played for Persian league in the level two. So I would say that would be still great, Stephanie. You shifted into the research and what you've done incredibly on the research early, super early, because of the retirement. Again, early retirement from your sport, and who knows if you uh, got to continue with your sport and the soccer. So maybe we missed someone like you in the uh, context of physiotherapy, and the world missed someone like you. maybe.
Who knows? I mightn't be in. Yeah, who knows what? I I was in my first year of physio when I ruptured my ACL, so I still would have been a
Mm.
physiotherapist, but I might
Mm.
not have gone into research. Who knows? There you go.
But it gave you more space to go,
Yes, of course,
involving
of
with
course.
professional and elite sports, the sport like soccer, would uh, obviously take the whole time and the whole
Mm.
energy, whole life of anyone, and
Yeah.
that's obvious. So you would be still happy uh, with that uh, thing universe gave you. So I know this is what I'm saying is not within your main research expertise, but I want to know your overall perspective on vulnerability of ACL as a whole in the persons who might be high risk individuals to get their ACL ruptured. Uh, I know there's much goes with it, but it would be still rewarding to hear your at least theoretical insights uh, on where research stands on this respect, vulnerability of ACL.
Vulnerability, sure. Yeah, okay. So one of the areas which is progressing is anatomical risk factors.
Hmm.
So, like the increased tibial slope is coming up as a predictor of injury. So, anatomical variations that may predispose someone to ACL rupture. We know there is a genetic component.
Hmm.
There's both genetic and there's a family history. In my own case, both my parents have ruptured their ACL, and I have
Oh,
two uncles that have had three ACL surgeries each. So,
how
and
bad.
that's really common. So it does run in families as well. Obviously, predisposing yourself to high risk sports is going to put yourself at risk, in particularly if you have other risk factors. So, cutting
Hmm.
and pivoting sports, in particular, contact sports. So, the types of sports have higher risks of ACL injury. And we know young females are one group that has a high risk relative to the same exposure as males
Hmm.
in those
Six
sports.
times more, maybe.
Yeah, I mean, yep, that's been quoted. And we don't know necessarily why. We hypothesize a lot of reasons. It
Hmm.
can be both environmental and societal, as well
Hmm.
as genetic and other factors. There's a body of research suggesting that women don't get the same opportunities as,
Hmm.
shall we say, young girls as boys to do a lot of running, jumping, pivoting, playing sport in the schoolyards, and they may develop differently in terms of strength and neuromuscular control.
Hmm.
Um, but also the same teams, if it's soccer and you have a male and a female team, it's often the male team that receives strength and conditioning, gym lessons. They're often playing on a better pitch at a better time.
Hmm.
Um, so whether all those factors collectively can also attribute to a difference in terms of uh, gender when it comes to ACL rupture rates is possible. And it depends. It's different depending on the culture that you're in and the
Yeah.
country you're in. Um, and then, you know, there's been a lot of body of work looking at people with, increased dynamic knee valgus, hip weakness, which could
Hmm.
predispose somebody to non-contact injuries. So certain landing biomechanics. There's certain things that we try to target with injury prevention programs, which are effective at reducing the likelihood of injury. So I guess that's a risk factor now. If you're not performing injury prevention, that would place you at greater risk of ACL rupture as well.
So, have you researched yourself or your team members on these topics so far?
Not me. It's not an area that I focus on, but a lot of my colleagues are looking at that.
Hmm.
especially ACL prevention. There's a lot of great researchers in Australia as well as in other countries overseas looking into ACL prevention. And they've developed a lot of different programs, and they all find the same thing. The programs work. They reduce the rates of ACL injury, but they're really hard to keep people doing it in the long run. So often once the study stops, they stop doing it, and then the injury rates start increasing again. So it's how it can really be implemented into trainings and into sport, and how it can be sustained over time as well. And you need buy-in from the coaches, buy-in from the team, the leadership team, the management, as to the value of doing it and as to doing it properly as well.
I guess I've got some researchers investigated the knee shape, which were really up to date. So it's, I guess, a wonderful topic to research on because of the data specifically we have available for women athletes. Maybe they got to place at the more risk for ACL injury when it comes to practices, to training methods. But what I see personally, most of our team here in Iran or some other neighboring countries would go to use with men data for organizing or scheduling training protocols and strengthening protocols specifically for women athletes. So that's something we have to consider. Thank you, Stephanie. We're moving now to the next part, which is screening an ACL rupture. Let's get this section started by imagining we have an athlete with ACL tear who comes, approaches us and asks whether or not surgery is needed in my case. The question is, what contributing factors derived by your new updates may set different cases apart from one another to pursue therapeutic modalities?
Yes. Yeah. Okay. So, yep. So my thinking there, firstly, if someone approaches me, do I need surgery? In most cases, I think the answer is, well, in my opinion, it can be a good idea to try rehab first. Because the reason is we don't yet know who needs surgery and who doesn't. We can't predict with any certainty who will have a successful outcome with rehab and who won't. So we need to explain that to them. We need to explain that around about 50% of people who try rehab have a successful outcome, and around about 50 will decide to have surgery. So what do you have to risk there? It's typically time. So at least 3 months of rehab to see whether your knee will become stable. Because if your knee doesn't become stable, then we'd likely recommend surgery, because we don't want people to have an unstable knee. And unfortunately, we can't yet predict who will have a stable knee and who won't with non-surgical treatment. In terms of healing, so this is a new sort of paradigm shift, I suppose, when it comes to ACL treatment. So the research is relatively new in this area, but we are seeing a lot of associations between types of injury and healing potential. So we haven't published that yet. We're running a predictive model so we can try to predict who's most likely to heal and who isn't, because that will likely help to inform decision making. If you're more likely to heal your ACL with non-surgical treatment, then you're more likely to be someone that benefits from non-surgical treatment. But the thing is, if you try rehab first, you can always have a primary reconstruction later.
Maybe
But
the same 3 months, ideally.
at least 3 months, typically, yeah. And then it's closely monitoring, as a physiotherapist, and making sure that the knee's doesn't have knee instability or giving way. Because we want to avoid that. We want to protect the knee health, right? So I think the other benefit of trying non-surgical treatment is, let's say that you have two scenarios, right? Someone has early reconstruction and the other tries rehab first. And this is a young female soccer player. Okay. So both of those treatments, she returns to soccer, maybe 14 months after injury. Now, playing soccer, around 1 in 3 young females will tear their graft after ACL injury. It's quite common in that group. So now let's say at 18 months, she suffers a new knee injury with each treatment pathway. So if she had early surgery and tore her graft, 90% of people injure their meniscus or cartilage at that time, and she's likely to undergo a revision ACL reconstruction, which we know has poor outcomes. There's a lot of research showing that revision surgery has much worse outcomes than primary surgery. On the other hand, if that person that tried rehab, they returned to sport, but then they had a new knee injury. So they might have injured their meniscus, they might have injured their cartilage, similarly to the other group. And if they healed their ACL, they may have retore that ACL, which can happen. So then that person's options are, do I try non-surgical treatment again? See if potentially my ACL may heal a second time, or I can regain knee stability. Or do I go and have primary ACL reconstruction? So if I would rather be in a position where I could have a primary ACL reconstruction than a revision. Does that make sense? So it in a way it's also postponing the likelihood of needing multiple surgeries, acknowledging that the first time reconstruction is performed has a lot better outcomes. Anyway, so I think that's another key benefit to trying rehabilitation first.
So from what you just said, it would be a kind of multifaceted and really complex decision to evaluate all those possibilities and odds, but still it would be better off to go with rehabilitation first, and it would be a win-to-win situation, whether we choose a delayed surgery or ending up with rehabilitation alone.
So there's some exceptions, like if there's multi-ligament ruptures with gross instability, if an MCL rupture, PCL rupture, ACL rupture, you're not going to try non-surgical treatment in that case, because there's so much functional or passive laxity and instability, it's unlikely to be successful. Certain more severe meniscus injuries with mechanical locking that require surgery, you typically do reconstructions at the same time. So there is exceptions where you would opt for surgery if there's a lot of more severe concomitant injuries causing kind of gross instability in the knee, is one instance. And in professional athletes, I mean, they often look at the timeline and they're often not willing to gamble because there's more certainty around the typical ACL reconstruction route. Normally by 12 months, they can get back to sport, right? A lot of people don't, but the timeline's more clear and we have a lot more experience with that timeline. But with non-surgical treatment, you're saying, okay, so we may be able to get back sooner, but we may have to delay and then have surgery and then another 12 months on that. So it's weighing up that pros and cons, potentially faster, but maybe longer versus something more predictable. So that's some of the challenges and pros and cons that need to be weighed up.
Yeah, but in cases who got much laxity on the knee, I guess there are much rare cases if we got a percentage of the people?
Yeah, actually, it's most common to have concomitant injuries, around 70% of ACL injuries. So it's less common to have an isolated ACL rupture. You normally have some injury to some other structure, be it MCL, meniscus, but it's not common to have a full rupture of multiple ligaments or a severe meniscal. So we're talking about the most severe concomitant injuries, not any concomitant injuries. So the cross bracing protocol, in that publication that we published in BJSM, the majority had, over half had meniscal injuries and over half had MCL injuries, and they seem to have healed with the brace. So most concomitant injuries have a chance of healing non-surgically as well. It's just if the combination of injuries are so severe that it causes quite drastic knee instability, then in that case, surgery is, I think, a really good option. So, including ACL and PCL combined. That's an example.
So to wrap it up, Stephanie, if we have a case with a high level of laxity and the comorbidities you just mentioned, maybe it would be better off going with surgery. But still, the finding isn't there, and there's much research on it.
Exactly. And this is we haven't spoken about the bracing protocol yet, but I think that's a little different because I think that period of progressive immobilization also, depending on the concomitant injury, may help heal other injuries at the same time. But if you're starting with quite aggressive rehabilitation without any immobilization, then any gross instability, of course, could cause knee giving way or something along that. But we're really talking about gross instability, not increased passive knee laxity on, a Lockman's or a positive pivot shift. We're talking about rotary instability, functional instability, which we want to avoid.
Thank you, dear Stephanie. So in one of your research works, I'm referring to the 700 Australian adults with ACL and the physiotherapist perspectives qualitatively over on this project. The most favorable option reported to be the most favorable option made by healthcare providers would be a surgical option without making the patients aware of the other options available, pros and cons, and all those things. I don't know if this is in your authority or in full control of you to answer this question, but I would love to hear your words. How do you think the health ministry and the law as a whole can step in to improve evidence uptake and support informed decisions, decision making on this respect?
The law. That's a good one. People do have legal obligations, medical practitioners, physiotherapists, in particular for more invasive treatments like surgery. They should have informed consent to undertake certain procedures and interventions. And in some cases, based on our research, people aren't receiving informed consent. Legally, they may be. So in Australia, in a lot of cases, unfortunately, what people are expressing is that they're not actually told any downsides to the surgery. They were only told about pros or good sides. And I think often it's when they're in the hospital, lying in bed, about to go and be wheeled into surgery, that someone comes out with a big checklist. And the first item, is this may cause death. you may bleed out during the surgery and you need to sign away, right? And the last thing you want to do is read and consider that when you're about to go in for surgery. So I think people just gist over it and sign. And that is the nature of informed consent for the surgery. But I think it should come much earlier, and it should be more of a discussion of the evidence and the pros and cons of the different treatment options, which is where that decision aid comes in. So I'm not suggesting any laws are changed or anything, but I do think there's legal obligations to provide accurate information that's based on evidence so that people can make informed decisions. Because there will be cases that come up where people are sued for malpractice and other reasons down the track. And it may become more and more common, I suppose, as the evidence base grows for alternative treatment options.
So that's why, Stephanie, you and your team created a patient decision aid. May you tell us about the practicality?
So if I could just add, it's not just surgery. So there could be a case where, let's say, a physiotherapist could be telling people, you don't need surgery, you'll have a great outcome. They could be saying just equally unbalanced information that's not evidence-based in support of non-surgical treatment. And that person could go on and damage their knee and develop arthritis and may then go and, so it does work both directions. It isn't only happening in surgery, it can also happen in the non-surgical space. So there's legal obligations in both surgical and non-surgical treatment.
So it's kind of providing the space to have enough knowledge for choosing either ways. And it's not biased direction to help patients. It's going to consider both ways and just giving our patients an image of either ways, pros and cons. That's what you meant.
Yeah, it's hard for clinicians to digest all the information out there. It really is. And there's a lot of misinformation from what should be fairly trustworthy sources as well. So it is hard to decipher what's trustworthy information and what isn't. And there's a lot of vested interests in this area and a lot of money to be made. So I'm not surprised that a lot of clinicians aren't on top of the evidence because it is very complex. And there's conflicting evidence and there's recommendations based on expert opinion that are complete opposite to what the evidence supports. So there's a lot of noise out there, which again was a reason for this decision aid, which is based on clinical trial and systematic review evidence, but we're going to update each year as new evidence becomes available as well.
You just mentioned earlier, back to where you ruptured your ACL and how your physician did guide you on the journey. So are you still seeing this kind of biased guidance? It hasn't changed yet.
Yes, absolutely. So in that study that you mentioned before, we separated what everyone with so again, it's very country specific. I was just at a conference in Copenhagen, and in Denmark they perform rehab first, and in Sweden, and so that there was a Swedish surgeon I was speaking with, and their practice is perform rehab first for everyone and then see who needs surgery. And that's been the state of play in Scandinavia for some time. But that's very different to Australia, America in particular. I'm not sure about Iran, what the current practice is, but when we questioned and interviewed and surveyed people that had ACL injury around Australia, we found that around 90% or 9 out of 10 surgeons had told patients that they need to have surgery or that surgery will have better outcomes. Which, based on the evidence, we just don't know yet.
I did read that out, that word. Go ahead. Sorry.
Yeah, once a surgeon tells that to a patient, they're very unlikely not to have surgery. And we also interviewed physiotherapists, and they sort of suggested that, yes, if a surgeon says that someone should have surgery, I don't even mention non-surgical treatment to them because they've already decided, and who am I to stand up against the doctor's opinion? So I think the referral pathways and the order that they see different healthcare practitioners can really influence treatment decisions as well. But no, I don't think it's not intentional in many cases, or just to make money. Again, a lot of bodies that are sourced with educating surgeons, the information they provide to surgeons is that surgery is needed to return to sport in most cases, that the knee's at risk of further injury if you don't have early surgery. So this is being passed on to surgeons through their own training. So it's not necessarily a fault of their own if they're passing that on to patients.
That's wonderful advice from Professor Stephanie Filbay. Thank you again. Yeah, I guess that would be wonderful to make our patients informed for all these things, but specifically in some countries we need to kind of go with law enforcement and what the health ministry do regarding unnecessary surgeries. So in Canon trial, we found that 1/4 of people with ACL injuries naturally cope with the surgery and do well with the surgery, who are named copers. So my question is, how should we know if we have such a potential, although you got to this topic earlier a little bit, so if you want to add something more, I would welcome.
Sure. Well, yeah, well, it was 50% randomized control. It's half of those that start rehab coped with rehab. You could look at it like that. So that was 50%. Well, yeah, of those who were randomly allocated, so not by choice. So the strength of that being a randomized control trial is that it accounts for differences. So a lot of time the evidence informing decisions is a poor research design where the groups aren't comparable. But in that case, if it's a randomized control trial, the benefit of that is the groups are comparable. So in people that were randomly given rehabilitation only, half of those went on to have delayed surgery, mostly within 2 years, and the other half, you could say, coped or had a successful outcome that was no different to the early surgical group. And even those who decided to have delayed surgery had similar outcomes to the early surgical group. So all three of those, rehab only, early surgery, or delayed surgery, had similar outcomes across a range of measures at 2 years, 5 years, and 11-year follow-up. So we then looked at that data last year. Was it published in 2024 in BJSM? And we went back and analysed the MRIs to find out in that rehab group, how many of them actually had a healed ACL. And we found that in those that were only treated with rehab at 2 years and hadn't had delayed surgery, it was 53% had a continuous ligament. So the ligament had rejoined. And we then found at 2 years that in those with a ligament that had rejoined, they had better sport and recreational function and better quality of life than the surgical groups, and better outcomes than those who hadn't rejoined, that remained fully ruptured. So that was an interesting finding. We weren't sort of expecting to find that. And that then led into our research looking at the cross-bracing protocol, which what that does is it immobilizes the knee in 90 degrees flexion by wearing a knee brace, and it reduces the distance between the two torn ends of the ACL and then holds it in a shortened position. Because with the knee at 90 degrees, the ACL is closer together in terms of its origin and insertion.
So for 3 months?
So, so it's at 90 degrees for 4 weeks,
Oh,
and then at each week, the knee braces increase to allow more and more movement within the brace. At 10 weeks, the brace is unrestricted movement, and then the brace is taken off at 12 weeks. But during that time, they're performing a lot of rehabilitation, a lot of strength work, neuromuscular control, weight bearing through the leg. So they're not inactive. Even when they're braced at 90 degrees, they're doing, things like wall squats held at 90 degrees, bridges. So they're active and using as much of that range as they can the entire time. And the other important things to note about this protocol is it's acute ruptures, no later than 3 weeks after an injury when the brace has started, and that they need some kind of DVT prophylactics, because if we immobilize an acute injury, there's a risk of a DVT. So that's really important, that medical component and medical management and a DVT prophylactic medication. So the first paper we published on this treatment found that 90% of people that underwent that brace had a continuous or signs of healing at 3 months on MRI. So that's 90%. And that was in the first 80 patients. And now there's been over 940 braced, and people have been braced in over 23 countries, actually. So, and we found that so the other thing about ACL healing, it's not just continuous or discontinuous. There's variability in terms of the quality of how that heel looks. So a bit over half of those with a continuous ligament look normal on MRI as if it was never injured. Normal thickness, normal tautness, and normal alignment. But then there's another subgroup where the ligament may be a bit thinner. It may be thinner along a portion, or it may be lengthened and have a bit of a sag. So we don't yet know how those variations in healing compare, how they relate to knee function, but also how they compare with the graft. And that was some of the key motivation for doing that.
That's the next question I wanted to ask. So you just responded now.
I've moved ahead.
No, I'm just saying that's something on the way. How the brace protocol could react to different ACL grades or the other stuff you just mentioned. So go ahead.
Yeah, so sure. So as I mentioned earlier, we're running a predictive model at the moment to decide who is most suited to bracing, because we think there's certain kinds of variables when it comes to ACL rupture that are best suited to having that thick and taut heel outcome, so the best outcome. And they're typically the less disrupted ruptures. So in terms of the distance between the two ends, so if the ACL is ruptured but still relatively close together, rather than really far apart, whether the distal part's flipped and sitting and lying, or dislocated and sitting alongside the tibial condyle or not, and whether the proximal part has been ripped off the femur, so whether it's avulsed actually ripped off the bone or not. So there's some of the key variables that we think relate to healing potential. In saying that, over 90% have actually regained continuity. So it's not related to whether they can heal at all. It more seems to be related to the quality of the heel, whether it's going to be thick, taut, and aligned normally versus thin or elongated. So hopefully we'll have research coming out in this area very soon. And we're looking at other patient-related factors as well, like hypermobility, age, mechanism of injury, a number of other variables to see if that relates to healing potential as well.
Oh, that's wonderful to work on the age matters and all those anatomical qualities of the patients, how it plays a role on the rehabilitation through bracing protocol or other kind of strengthening protocols. So Stephanie, thank you for all of these wonderful works you're doing. How about the inclusion criteria for getting into bracing protocol based on your study?
Well, that's a great question. And then it depends, right? So that initial study that we published in BJSM on the bracing protocol, other than time since injury, where everyone was within 1 month of injury, everyone was braced, all kinds of injuries, concomitant injuries, concomitant MCL ruptures, meniscal injuries, and all kinds of ACL ruptures, even the most disrupted. And that achieved the 90% continuity rate. But as we're learning, there seems to be a group that may have even better outcomes. So the question is whether sometimes in a research design, you want to do it within a group to increase the likelihood of having the best outcomes possible. But there's other settings where, you may explain to a patient and they might want to try that treatment, acknowledging that the odds are maybe a bit lower of having the best heal. But it isn't black and white. You've got people that have the most severely disrupted ACLs or are quite longer away from ACL rupture and then achieve a perfect looking heal and perfect knee function and return to sport. So it isn't as if you can't. It's more around the likelihood, and that's where we want to go with a predictive model so we can maybe give people some information to inform that decision making, like, you're this much more likely, with this presentation to achieve a positive healing outcome versus not. And we're not quite there yet with that information, but definitely time since injury is a big one because we see, like some people say, I injured my ACL 3 months ago. Can I do the bracing? By 3 months, your ACL is going to have, if it was to have healed, it would have started that process already. Right? So we think it's too late to benefit from immobilization and going through that. We're not going to put someone through that if we don't think it would benefit. And at around 3 weeks or later, you can see in some cases the ACL retracts and rounds and caps over.
Yep.
And there's a big gap. And if that's the case, in most cases, it's likely, again, too late to benefit from that immobilization. Kind of like a bony non-union of a fracture when you start to see it cap because it's not healing. So yeah, I'd suggest within no later than 3 weeks after injury. No injuries that require surgery, obviously. So if it's a severe bucket handle meniscal tear with mechanical locking, you're not going to brace them. Now we're not bracing full MCL ruptures because they get a bit stiffer. So we're doing a more accelerated bracing protocol where they're not immobilized at 90 weeks. If they can't take DVT prophylactics or if they have an increased risk of DVT because of some other medical condition, then you're not going to put them in a brace. So that's really important. And can they cope with immobilization? So if they need to drive a car or they need to be on their feet for work and they can't have a period of immobilization. I mean, people use knee scooters and things to get around, but certain people that need to drive mightn't be able to do that. If there's stairs they need to go up and down, they mightn't be able to cope with that brace. So also around their lifestyle and whether they can take that on. In saying that, in the first 4 weeks after reconstruction, you're also pretty immobile in terms of function, but there's still another option, which is just rehabilitation. So in that case, if someone couldn't take time off work or family or caring roles, then maybe rehabilitation alone could be the best option for that person. That is
and
probably
psychologically is really key. A person being psychologically strong enough to go with such a challenging protocol and hard working to stick to rehabilitation as best they can. Maybe psychological factors may plays.
Yeah, it helps, but that same person is likely to struggle with post-operative rehabilitation, which is long and even longer, up to 12 months. So you kind of need that motivation no matter which treatment you choose. Unfortunately, there's no great treatment option, which is do nothing, do no rehab, do no strengthening. That's not, I mean, it's always an option, but I wouldn't think someone's outcomes would be overly great if that was the case. And some people think that surgery is a quick fix. And hey, I'll go and have surgery and get fixed, and then I don't have to do anything. But we as
That's a very
physiotherapists in
common
particular know.
misbeliefs everywhere I go.
Yep.
Okay, that's it. Dear Stephanie, could we say female athletes, based on one of the studies I checked out, female athletes have genuinely more potential to succeed by non-surgical ACL rehabilitation?
I don't think the evidence is clear on that. Yeah, I'm not aware of.
You're aware of Gillingham and colleagues 2018 is the study find out.
Yeah, okay, yeah. I mean, their study, so the Delaware, I assume that's the Delaware Oslo cohort study, or one of. So in that study, the non-surgical people were advised not to return to high-level sport and high-level cutting sport, if that's one of the studies you're referring to. So I guess a group who was given that advice, maybe in that case, there was more females who were not high-level athletes potentially in that non-surgical. I'm not sure. Yeah, I'd have to look into it. But again, that's the fact that it wasn't a randomized controlled trial, so the groups aren't quite the same. And so I'd want to know a bit about the characteristics of that non-surgical group. But as far as I'm aware, that hasn't come up in any systematic reviews as being a consistent predictor of better outcome with non-surgical treatment. Yep. We just don't quite have that. And the other thing is age. So age and sporting level, I think. People will often recommend surgery if someone's young and is playing high-level sport. And I kind of say, well, why is that? We don't have ever. So the return to sport rates are similar whether you have surgery or not. And we know younger age is puts you at risk of tearing your graft after surgery and worse outcomes, particularly if you return to cutting and pivoting sport. But the same evidence isn't there showing that young active people have worse outcomes with non-surgical treatment. Doesn't mean that that's not the case, but the same evidence doesn't exist at the moment. We know that they have worse outcomes with surgery. We don't yet know that with non-surgical. So why then are we saying they must have surgery? I don't think the evidence is there to support that sort of thought process either at the moment.
Correct. I don't know either if how much was the design of that study powerful, as this is really key in the studies, whose methodology targeting ACL context. We're gonna repeat the last questions, the last couple question. Stephanie, psychological drawbacks of ACL reconstruction have been reported to influence the quality of life, as like your PhD thesis you worked out. Even from 5 years up all the way up to 20 years, it will impact the quality of life. So have you got any psychological output from cross-bracing protocol or other trials you recently led?
Only in terms of psychological and the cross-bracing protocol, we've only published 12-month outcomes, including the ACL qual, which is an ACL-specific quality of life measure. But we need longer-term follow-up. definitely beyond that, and that's the plan, to follow people at 5 years and 10 years and understand. We don't have that yet because the research is too new. There's research coming out of Sweden analysing the narcox cohort that's looking at healing and relating healing on MRI to other clinical outcomes as well, and patient-reported outcomes. So that will be soon published at some point this year as well. So I think we're going to see more and more research coming out on ACL healing, because it's a very new area, and we can address a lot of these knowledge gaps. But a big knowledge gap is longer term outcomes. We just need more research in that area to understand, as you say, both the longevity of the ACL, but also long-term function, long-term re-injury rates, and quality of life in the long run as well. As well as osteoarthritis. So can a naturally healed ACL have a lower rate of osteoarthritis development than surgery? We don't know yet.
What about the osteoarthritis rates as complications and other comorbidities in people who passed rehabilitation alone compared to people who passed the ACL reconstruction?
Yeah, so the recent Umbrella review by Kate Webster. So she was the first author, I believe. So an Umbrella review is a systematic review of all existing systematic reviews. So when it comes to osteoarthritis, comparing treatments, that's a good design, because there's a lot of systematic reviews out there, and they're not all consistent with what they found depending on the year they were published. Anyway, that Umbrella review found a higher rate of radiographic osteoarthritis in people that are surgically treated compared to people managed with non-surgical treatment. And that's shown in some of the more higher quality recent systematic reviews as well. But the caveat there is that's radiographic, so it's just what we see on X-ray. It's not necessarily symptomatic. So we know when it comes to osteoarthritis, what we see on X-ray is not always associated with people's symptoms. People can have osteoarthritis in X-ray and no pain and no symptoms. So I say that the rate of radiographic osteoarthritis appears to be higher post-surgery, but not necessarily symptomatic. That's more, we don't know that. That same evidence isn't there.
So what about the meniscus tear as a other comorbidity in terms of comparing between rehabilitation alone and surgical method?
Yes. Yeah, so there was a systematic review in BJSM in the last couple of years that tried to answer this question, and they found that evidence was too weak and too poor quality to inform whether surgery can reduce the rate of additional meniscus tears. But there was a paper published late last year, again in this narcox cohort, which is over 200 people in Sweden that performed rehab first, and then a group went on to have surgery. And they followed them up over 2 years, I believe. And what they found is that those who were treated with surgery had more new knee injuries after surgery than the non-surgical group. And they plotted that in terms of both meniscal injuries, and there was in terms of additional surgeries required as well. So again, the evidence isn't conclusive, but if anything, it could even be in the other direction. So it's certainly not a strong case to say that surgery reduces the rate of meniscal injury. And I mean, it depends a lot on the methods, right? So if you had a non-surgical group that never did high quality rehab and had an unstable knees that was never picked up, and they continued to have instability episodes, then of course someone like that would have a higher risk of meniscal injury. But that isn't recommended management. Recommended management is to ensure that knee is functionally stable and that person is ready and able and appropriate to return to sport before they do. And if there is signs of giving way, then they should have crossed over and had surgery. if that knee is going to be functionally unstable. So it does depend a lot on where that data is coming from in terms of the research design, which may be why there was a higher rate of new knee injuries after surgery in the narcox cohort, because everyone performed rehab first and they were monitored for instability.
So in one of your research works, I mean, reference to one of your research works, the instability term would feature differently between healthcare provider, physiotherapists. So do you have anything else to add to how we define instability? It would be something targeting functionally the muscles and all the tissues around the knee, or something structurally targeting the biomechanic of the knee.
Yep. Really good question again, and it's not so clear cut for a number of reasons. But I think there's a spectrum of instability, right? So ideally what we mean by instability is that the knee's functionally unstable despite sufficient muscle function. So despite sufficient neuromuscular control and strength being regained, that there's still a functional instability there. Because what if the knee gives way at 8 weeks after rupture? Does that mean that that knee will be functionally unstable at 12 months? Not necessarily, because it's still very early after the rupture and the muscles haven't regained their strength or the neuromuscular control yet. So, yeah, true, definite instability is that despite muscle strength and neuromuscular control, there's a giving way episode. So a giving way episode, I would call, in most cases, causes a person to fall to the ground, in most cases, and causes an increase in pain or swelling. So that is what I'd call an instability episode. But it does need to be differentiated by other things that can look a bit like that. So, for example, if we're managing people with patellofemoral pain, we know the knee can kind of buckle beneath them, and that can be associated a lot with weakness, muscular weakness, a little bit of swelling or inflammation in the knee can cause your knee to buckle, more so in an anterior direction. So it's not rotary instability. So, yeah, and then you can have this sensation where people feel like their knee's gliding and sliding a bit. Maybe they haven't fallen down, it hasn't grossly given way, there's no gross episode of instability, but is that true kind of micro instability? Are they feeling that increase in tibial translation or rotary instability in the knee? And there's not a lot of research around that. So I don't know that I don't have a clear answer for you. I think there's variations in what we mean by instability. And from a research perspective, we need to define it better, exactly how we assess it and measure it. And I guess we need more universal ways for assessing it. And these days, with new developments in technology and wearable devices, hopefully we can advance what is the concept of instability and how do we measure it? How do we predict it? Because it is so important when it comes to ACL rupture.
That's wonderful remarks from Professor Stephanie Filbay. I hope all the clinicians and healthcare professionals are here to listen and take the best they can from our meeting. I'm finished. Stephanie, just to make this meeting with a more happy ending, let's share with our viewers and listeners any kind of life changer or rewarding stories you wanted to appreciate or appraise here.
Oh, inspirational words. For people with ACL rupture, I mean, there are a lot of people who
It could
are
be
able to...
the athletes, the girl athletes, who kind of
Yeah.
expose
Yeah.
some challenges, whether it's injury
Yeah.
or other things. Yeah, it would be
Yeah.
within the life as a whole.
Yeah, exactly.
Okay.
I mean, resilience is a very important trait, and nothing builds resilience like an ACL rupture and going through that kind of hardship. And you can come back stronger, and you can. People say, I've been through that. I know I can do anything now. And it can make you a stronger and better person, even if you don't return to sport because of it. If you look at it in a positive light. And if all else fails, you can become a ACL researcher. So there you go.
So that's what I
Yeah.
mentioned earlier in this talk. That one of the reasons you
Exactly.
shifted
That's
to
why
this
yeah.
incredible circle of work, and this is why mm, I, as an early career researcher, I'm proud of you and your colleagues with the works you're incredibly doing and have done. Thank you again, dear Stephanie, for joining our program. I know that this week's kind of were uh, crazily busy weeks for you, and I treasure your contribution to this talk. Thank you so much again. Have a wonderful day ahead.
Yes.
Oh, maybe night. Yeah,
Evening.
you're in
Yeah.
night.
Oh, good.
Um,
Yeah. Thank you. No, that was great. It was a good discussion, and I think we chatted about some things, some different things, and it was good. Always enjoyable. So thank you.